and thank you for being with us tonight for this very special virtual neighborhood health series. I hope all of you are doing well in these very challenging times. This series was created 4 years ago with the goal of bringing our community together in person to learn more about healthcare topics. We've had many sandwiches together, asked difficult questions, and shared personal stories as a way to connect to our fellow neighbors and to learn. In light of our current public health situation, we thought it was more important than ever to be here for one another as we are tonight. Thank you for being with us here virtually, and we hope for your continued good health and safety. We received many thoughtful questions from you. We will answer as many of them tonight as we are able. Because of the numbers in virtual attendance, tonight's event will be in a webinar format. If there is time at the end, we may answer any additional questions from the chat functionality. Now for some thank yous. I'd like to thank Clark County Credit Union for being an incredible community partner and sponsoring this series. CCCU continues to be there to serve and protect their members during this time. Clark County Credit Union will speak at the end of the session, as they always do, but they will share how to avoid the increase in banking scams that have emerged during this time. I would also like to thank Roseman students, faculty, clinicians, employees, alumni, and Board of Trustees members. Many of you are watching tonight from Utah, Nevada, and beyond. You are out there on the front lines making sacrifices every day. We could not be more proud of you and of all the healthcare providers who are supporting communities across America today. Finally, I would like to thank our presenters who have made time to be here tonight to answer your most pressing questions. They are among the frontline providers working hard to keep our community safe and healthy. And now for some introductions. Dr. Thomas Hunt joined Roseman University College of Medicine in August of 2015 as professor and chair of family medicine. As a physician who has been involved in medical education almost his entire career, Dr. Hunt jumped at the opportunity to help shape Roseman's new medical school. Dr. Hunt graduated from Cornell University with a BA in mathematics and received his MD degree from New York Medical College. He completed his residency training in family medicine at Marathon Memorial Hospital in Martinez, California. Dr. Hunt has practiced in Nevada for the past 18 years and has been a member of the Clark County Medical Society for 10 years. Dr. Hunt is a graduate of the Teaching and Learning Fellowship at the Keck School of Medicine and is currently finishing the AAMC Leadership Education and Development Certificate Program. Recognitions include the E.W. Richardson Excellence in Teaching Award, 2013 Healthcare Hero Community Partner Award, and the 2005 Nevada Family Physician of the Year. Tom and his wife have been married for 29 years and have 5 children. Since novel coronavirus appeared in China in December 2019, Dr. Christina Madison, an expert in public health, has been frequently called upon by local, state, and national media, nonprofits, and businesses to answer questions about the disease. Dr. Madison is the past president of the Nevada Public Health Association with an intimate knowledge of the impact public policy and legislation can have on communities. A trusted and valued healthcare professional with over 12 years of experience in public health and over 15 years experience as a pharmacy professional, she has received multiple awards and recognitions for her patient counseling skills and public health, vaccine, advocacy, and leadership, including the Silver Syringe Award in 2010, 13, 14, and 15, and Public Health Leader of the Year Award in 2014 from the Nevada Public Health Association, One-to-One Patient Counseling Award by Pharmacy Times, and most recently being inducted as Fellow of the American College of the Clinical Pharmacy for her sustained contributions to the organization and profession of pharmacy. Dr. Madison is currently an associate professor of pharmacy practice with Roseman University of Health Sciences. She maintains 2 active clinical practices with Hunt Ridge Family Clinic, which focuses on the LGBTQ community, and is one of the largest providers of HIV prevention and gender-affirming care services in the state of Nevada, as well as Volunteers in Medicine of Southern Nevada, where she offers immunization and communicable disease care. Dr. Madison actively participates in both state and national pharmacy and healthcare organizations to facilitate awareness of healthcare policy, education, and advocacy. At this time, I would like to welcome Drs. Hunt and Madison.
Thank you. Thank you so much for having us.
Thanks, everybody.
Yeah.
Well, we're going to spend the next hour or so reviewing all the questions that were sent in. There were too many to get through in an hour. In fact, some of these questions we could literally spend an hour on. Before we get into it, I wanted to just make a few thanks again. Thank you to the audience. I know we have Nevada, we have Utah, and probably some people from even further out. Thank you for spending your time with us. I want to thank Vanessa Maniago for putting this together. I want to thank Jason Roth, who's done a lot of the work getting the word out and making sure the media, and especially I want to thank Cameron Haymond, who is our IT specialist extraordinaire behind the scenes. I do have a disclosure. We have one expert on the panel, and that's Dr. Madison. I'm a family doctor. I'm very interested in this and have read extensively as well as taking care of patients with COVID-19. But honestly, given how new this is, there's very few people who could consider themselves experts in the world on that. Dr. Madison, anything you want to say before we jump into the questions?
No, I think you did an excellent job. Obviously, both of us have been called upon in the media, and I think this is just a great opportunity to really dive in. So I'm going to go ahead and share my screen so that we can go through the questions, and we have sort of a landmark or a landing page here.
And also while we're doing this, of course, I also want to thank the Clark County Credit Union for hosting us. And I'm looking forward to hearing some information on how to prevent us all from being scammed, because there's a lot of things out there that are looking to grab our money in this time of crisis.
Yes, absolutely. So let's get started. Okay. First question.
Okay, so let me read this first question. So what is a virus, and how is this virus different from some of the other viruses out there, specifically influenza, SARS, and MERS? So let me start by talking about, as we all know, COVID-19 is a coronavirus. There are hundreds of coronaviruses, most of them that are found in animals. Pigs, camels, bats, they run the gamut. There's actually only 7, including COVID-19, that have been shown to cause disease in humans. 4 of them cause the common cold. And this is important because if you think about it, we all get the cold occasionally. Some of us get it several times a year. But the coronavirus that causes the common cold, we don't get long-lasting immunity from those coronaviruses. One of the big questions that we'll address later on is, if I had the COVID-19, am I good forever? You know, we don't know for sure, but we have to look at the other coronaviruses and how they act. While we develop immunity immediately, we do not get immunity from these particular ones that lasts forever. The other ones are a little more interesting, in my opinion, is SARS and MERS. These are the severe acute respiratory syndrome and the Middle Eastern respiratory viruses. These are both also novel viruses, novel being new. We had never seen them up until the last 20 years. It's scary and also something to note. This is the 3rd virus that has jumped from animals to humans, all in the coronavirus family in the last 20 years, that have caused significant illness in humans. The first one, SARS, started in China. It started to spread. This was a real success story for public health. We were able to identify it early. We were able to test it early. Once we identified the individuals who had this, they were quarantined, and we basically stamped it out in 2 years. It was there. It started to spread. We all got nervous about it, and then it just kind of petered out. And a lot of that had to do with the actions taken by the public health societies around the world. MERS, on the other hand, is actually about 10 times more dangerous than coronavirus as far as death if you got it. However, it's never really propagated around the world. A pandemic, which we are in now, is a virus or a disease that propagates not only in one geographic region, but spreads to other geographic regions. So when you went from the continent of Asia to the continent of Europe, that's when we started to see it spread in Europe. It became a pandemic. MERS is still there. It sporadically causes outbreaks, but seems to be isolated more to the Middle East. It's something that we don't know as much about. There hasn't been as much study done. Christina, anything you want to add to that as far as the coronaviruses and some of the background?
No, it's great. One thing I would want to say is that I think because this is new and novel, we are still learning. But one of the things that we do know is that the COVID-19 virus is about 80% genetically similar to SARS. And so a lot of the early modeling that we used to predict how this infection would be kind of migrating throughout the world were based on SARS modeling. And what we know now, which is very different, is that this virus has actually quite a long transmission phase. So when we contrast that to something like influenza, where you're potentially infectious for maybe 2 or 3 days, then we look at COVID-19, and now we're looking at anywhere from 2 to 14 days. And so that's part of why we think that this has gone as far and as quick. That and the fact that now new data is showing that you see a lot of asymptomatic spread of the infection, which is not like some of these other infections where you're very noticeably sick or ill before you can transmit it to others through those respiratory droplets.
Yes, the more we learn about this, we are realizing that probably the vast majority of people who have it are asymptomatic. They're saying upwards of 80% are mild or no symptoms. I can tell you that personally in my practice, I have taken care of 3 people who have tested positive for this. 2 of them were tested because they were in healthcare and had contacts. Both were asymptomatic, never developed symptoms. Third person had one isolated temperature of 100.4, also didn't develop symptoms. The problem is that it spreads quickly, and those who actually do get it and get it bad, they're ending up in the hospital very, very sick. And, this, as of today, more people in the United States have died from coronavirus than died in the Vietnam War. So the numbers are real.
Yeah, we hit a very important milestone yesterday. We were now at 1 million cases, so.
Yeah. Something else just to mention about viruses before we get to the next one is, viruses are interesting. They're very small. They're basically an envelope packed with DNA or RNA, genetic material. Most people would say they're not really alive, though that's debatable depending on what you consider life. But it doesn't live for very long outside its host. It needs a host cell where it invades, and we'll talk a little bit more about this. It propagates, and then it will either kill that cell, kill that host before it goes on, but it needs the host to quote unquote live and propagate.
Yeah, that's really interesting that you brought that up. I think, moving on to the next question that we have in, looking at, does it move on? Does it, kill or attack the host, or does it actually cause the host's immune system to be overwhelmed, which is what we've now seen with COVID-19. So.
Right. Okay. So one of the next questions that came up is, how is this virus spread? And then, so I'm going to start with that. And, quite simply, it is generally spread from respiratory contact. If I have the virus and I'm shedding the virus, most of it's going to be shedding out of my mouth when I breathe, when I cough. We are also now realizing that there's actually quite a heavy burden of the virus in many people's GI tract. They're finding it in sewers. There was a study done in Massachusetts. They found a lot more than they expected in the septic systems. There was something else today that came out that said it could live for 22 days in feces. So it goes throughout your body, but for the most part, where this is being contracted that we've recognized is respiratory. Though I think we may see that there may be a fecal oral route as well. Getting back to respiratory, when people cough, it goes out into the air. One of the things you'll have to think about is, besides coughing, thank you, Christina, for doing that for me. it can also land on surfaces and live for various amounts of time. And there's been studies that looked at different materials, and it will last from a few hours to maybe even a few days. But the main one is, again, respiratory. And that's why you're seeing people now being told to wear masks. The masks aren't so much to prevent you from getting it, it's from you to prevent you from giving it to other people. If I have a mask on and I cough, it's less likely to go as far as than if I had a mask off. So that makes some sense. You know, talking again about could it be on surfaces, doorknobs? It absolutely can. When you go to the grocery store, can it be on the cart? It can. But the other part of this disease that I believe, and we still don't see a lot of studies, is it's dose dependent. So if you have somebody who's very, very sick, think about it as they're teeming with this virus and they're coughing, that room could get filled. The closer you are to that person when they cough, the more higher dose you will get. Therefore, you're more likely to get sick and you're more likely to get more severe disease. On the other hand, if I touch a doorknob several hours after somebody else and then maybe touch my face, the dose is going to be a lot less. So chances are I'm going to get less sick. More and more will come out about this as we go, but just remember, really the vast majority of this is spread person to person through respiratory. So when we start talking about protective mechanisms, they're all around trying to prevent that spread. Dr. Madison.
Yeah, no, I was just going to add a couple more thoughts to that. So, you know, again, wearing a facial covering or wearing a mask works best when we all do it, because my mask protects you from me, and your mask protects me from you. So it works best when we all wear it. And then I also wanted to echo your point about the amount of inoculum or the amount of exposure. And also it's the amount of time. So I really, you know, my experience is in the public health realm, and I spent a decade with our local health department. And one of my main functions was that I saw patients in our tuberculosis clinic. And I see a lot of parallels with how we treated our tuberculosis patients and how, you know, how COVID is transmitted. So it's not just, you know, the fact that those patients were positive for TB, but how positive were they? How much, how infectious were they, right? And so it was, how infectious are you? And then how much time did you spend in that space with that infectious person? And so we used that information when we did things like contact tracing and contact investigations to try to determine, you know, what really was your risk. You know, was it you passed in the same, you know, elevator, or were you actually in the same restaurant eating the same foods for, you know, over an hour? So I think, you know, when we look at risk, it's, you know, it's not just, did you touch a surface and was it potentially contaminated, but how much of the virus is there and how long were you exposed to that amount of the virus?
Excellent points, yes. You know, we do have at Roseman University a dental school, and there were some questions about specifically dental procedures and the practice of dentistry. I'm going to expand it a little bit and talk about medicine as well as dentistry. But medical offices, dental offices are changing the way they do business, and it's already begun. In both medicine and in dentistry, I was speaking with one of our professors earlier today. One of the things we're doing is screening everybody who comes in the offices. Do you have a fever? Taking a short questionnaire that says if you're at high risk or not. Though as time goes on, more and more of us are. You know, when you go to the office, one of the things you're going to see with dentists, they're working in your mouth. We can never be sure. You're going to see a lot more of your dentists wearing N95 masks. You're going to see a lot more dentists wearing full facial covering to lower their transmission. They're also working on, there's actually this, you know how when you have your work done on your mouth and they have to suck the saliva and the juices out of your mouth, they actually have a new vacuum that will not only do that, but it actually will very quickly and strongly pull all the particles that may be aerosolized in the air around your mouth right out of that work area immediately, as well as guards that they're going to be using. So things will be changing pretty rapidly, both in medical and in dental practices.
Yeah, and honestly, I mean, these are things that we have to do now to protect ourselves because we don't have what's called herd immunity. And, you know, we're going to talk a little bit later on about sort of, you know, what our options are for treatment and prevention, but really until we get to a point where we are able to achieve that herd immunity, either through natural infection or through vaccination, these are just the changes that we're going to have to make in order to make sure that we're keeping ourselves as healthcare professionals, but also our patients well and safe.
Good. Yes, thank you. Okay, our next question is, who is at risk for COVID-19? Well, first of all, we're all at risk. You know, one of the things that we've seen, there are people who are at higher risk, and we'll go over that, but anybody can get this. We're seeing very young, very healthy people come down with rip-roaring cases and even die from this disease. I think a lot of people have had a fairly cavalier attitude, and I think you just have to be careful because, again, it's dose response related, and we're seeing very, very healthy people. So everybody's at risk, but who's at most risk? What we're seeing is several categories of people who seem to tend to get this disease more severely. The first category is the older you are, the more likely you are to have a severe case. Specifically, we're talking about the over 65 population, and specifically over 65 living in a nursing facility or other long-term care facility, and also people who have concomitant health problems. So if you're 90 years old, living in a nursing home with diabetes, heart disease, and maybe some lung disease as well, you're at super high risk. As we kind of ratchet down, anybody with serious medical conditions is at increased risk. And that includes heart disease, liver disease, kidney disease, diabetes, asthma. There's been some question about high blood pressure, whether or not that's a risk factor. I'm seeing that that's become less and less important the more they look at it. In fact, the latest study that I looked at, they said in China during the first, they looked at 1,100 people, and I think they said 15% of them had high blood pressure. More people had high blood pressure of those 1,100 than any other disease. Yet when you looked at the general population of that community in China, the incidence of high blood pressure was 40 or 50%. So actually high blood pressure does not seem to be a risk factor, except that it runs with all the other culprits, right? The older you are, more likely of high blood pressure. If you have diabetes or heart disease, you're more likely of high blood pressure, et cetera, et cetera. Gender, it seems to hit males a little bit more than females. As far as race, we are definitely seeing in the United States underrepresented minorities, specifically the African-American population, the Hispanic population, are being burdened with this much more than you would expect based on just simply what percentages, and we're seeing that even in our community here. The reasons for that are multifactorial. While we don't fully understand, we do think while there may be something genetic there, it's more likely has to do with what we call the social determinants of health. You know, what was your pre-existing health before? How's your nutrition status? How's your living conditions? Are you living in a multi-generational household? Are you living in apartments as opposed to being spread out? How's your access to health care? I could go on and on, but there seems to be something that is affecting Hispanics and African Americans in our country and around the world more so than other ethnic groups. Certainly poverty and overcrowding is contributing to certain populations being hit harder. You know, if you look at New York City and how New York City is many, many people on a small island compared to a community like Nevada where we're more spread out, it's not surprising that more people per capita are being ill in New York than Las Vegas. So I also think we've done a good job here of social distancing early. Dr. Madison, want to weigh in?
I would agree with all of those points. You know, one other thing that I was going to bring up as far as risk factors is the use of, you know, inhaled products, so nicotine products, cigarette smoking and vaping. We've seen some, you know, if you have underlying lung damage, especially in young people that are becoming sick with COVID, it seems like that is a factor that's causing their disease course to be worse. And potentially requiring additional advanced, you know, medical mechanisms such as ventilator support and some things like that. The other thing too is, you know, with the young people that we are seeing getting COVID-19, because this does seem to have a higher risk in those who are older. I do want to make sure that I state that we are seeing a fair share of people between their 30s and their 40s. And they're presenting with very interesting presentations. And one of the things that's being talked about now is this COVID-19 related, what we call coagulopathy. So it basically makes your blood really sticky. And when that happens, it puts you at risk for conditions like heart attack and stroke. And so we are seeing some of, you know, the younger individuals coming in with some of these, what we would ordinarily think would be conditions of younger people, like stroke and heart attack. So that's also something that we're seeing in addition to that kind of overwhelming cytokine storm that occurs from COVID-19, which is where the immune system basically gets overwhelmed and it actually becomes more of a hindrance than a help. And that's why people are becoming very, very sick with the disease.
Yeah, we're seeing that this goes beyond just a simple respiratory infection that we usually take care of, a pneumonia like we see it. It really does affect the whole body.
Yes.
There's reports coming out of New York City that they're seeing many, many more patients going on dialysis than they would expect. So they're saying, you know, is it just because this is such a severe insult to the body, or is there micro infarcts that are happening in the kidney, or is the virus itself attacking the kidney in ways we don't really understand? You know, there's more to come. I'm sure, Dr. Madison, you saw the 5 case reports on young people with major large vessel strokes out just today. So very timely. Thank you.
Yeah, and we have seen children as young as less than a year of age who've unfortunately succumbed from COVID-19, but there were multiple other factors that seemed to, you know, come in play with that particular individual's disease course. But what we've seen so far is that it seems like younger children, those under the age of 12, seem to not be as impacted as, you know, older adults or, you know, sort of that middle age. I hate to say that because I resemble that remark now that I'm in my 40s, but I do think that, you know, the big takeaway that I would say for this is that we are all at risk. And knowing what your risk is really important when you're determining whether or not you want to, you know, do things like go out in a public place or, you know, decide to do any kind of travel or, you know, those kinds of things I think is really good for determining, you know, how our movements are moving forward.
Absolutely. And, you know, the thing about question was asked, are infants at increased risk of severe symptoms? As Dr. Madison said, is actually what we're seeing is children tend to have very, very mild symptoms. And we're guessing that many of their cases are subclinical, meaning nobody even noticed they were sick because they weren't. One of the studies that came out of China showed that they reviewed over 72,000 cases, and it was less than 1% of the cases were in children less than 10 years old.
Yeah.
So while there's been some case reports of very, very sick infants, they tended to be kids who were born prematurely or had other things. For the most part, you know, you need to protect your children too, but thankfully this is a disease that's not hitting children as hard as the older population.
All right, so I'll take this question and I'll ask you to comment as well, Dr. Hunt. So what has been determined as far as immunity to this disease. And so as we've kind of already alluded to, we know that this is a novel infection or new. And so the reason why this is a pandemic and it is now gone all across the globe is because there's no known immunity within humans to this virus. So what does that mean? It means that our bodies have never seen this infection before and therefore have no immunity to fight it off if we're exposed to it in the environment. So if you get infected with COVID-19, as far as we know right now, that does not mean that once you recover, you will not be able to get it again. So there have been cases where people have been infected, have had illness, have recovered, and then have gotten it a second time. There's also maybe some instances where maybe you have someone who's maybe recovered, but they have some underlying viral replication. So they may still be testing positive when you do an RNA test on them to look for the virus. And so when we're looking at who's immune, that immunity may be waning. So even if you've had it and recovered, that doesn't automatically mean you can't get it again. We think that if you do have some immunity, it's based on, maybe a few months. We're not talking years, or we're not talking like when you have something like hepatitis A virus, where once you get it one time, you're immune for life. That is not this infection. Same thing with influenza, because there's always circulating strains depending on the year, there's already underlying immunity to other strains of influenza. That's why we don't see sort of what we consider right now, sort of just this catastrophic spread and such severe illness and death so rapidly associated with COVID-19. There's no immunity within humans right now, and it really just has to run its course until we have vaccination. And that herd immunity that I'm sure you guys have heard that term before really is referring to the fact that either you've gotten the infection naturally, so you've been exposed and you've had it and then you've recovered, or it's man-made or induced, where I give you a vaccination, which is basically a bunch of chopped up little bits of the virus. I introduce it to you, and then your body induces an immune response. And then you're protected, but that still takes a little bit of time, right? So vaccines are not a silver bullet either. It still takes about 10 to 14 days before your body develops that immune response. And so, once we do have a vaccination, and I'll talk about that in a little bit later, it's going to take some time. It's going to take some time to get the population immunized. And then it's also going to take time for that to really kick in and start to developing immunity. So the specific question that was asked is, do we know yet if this is a one-time virus or can it reoccur? And I will absolutely quote Dr. Fauci, and tell you that this is absolutely going to come back. And it's going to come back in the fall. And based on our human behavior, it's going to determine whether or not it comes back with a vengeance, or if it comes back and we're able to manage it. So we're going to have to change how we operate. There's a difference between saving lives and looking at livelihoods. So we need to take all of those things into consideration. If you are somebody who's immunosuppressed or has one of those chronic medical conditions that Dr. Hunt mentioned before, those individuals, we really are going to want to limit their contact into the general society and general population, because your risk is very high. And we would want to make sure that we can get you to a place where you are protected. We want to get that little protective bubble around you if possible. And then let the people who do have maybe a stronger immune system and are able to go back out and be in general public, and if they do, potentially get exposed, won't have a complicated course associated with the infection. Dr. Hunt?
Yeah, I think you covered it very well. Thank you, Dr. Madison. The basic answer is we don't know. These people who've been reported to have had it twice, it's not really clear if they got it twice or the tests weren't really that well, or they were recovering and then they had a setback. It's really not clear. We definitely are hearing from all the experts that we are going to see this again in the fall. Those of you who know about history, have read it all about the Spanish flu, know that the second wave of the Spanish flu was actually much worse than the first wave. Yeah, so that's something we don't know. And then this immunity, is it immunity for a lifetime? Is it immunity for a few months, or is there no immunity? We just don't know yet. We just don't know yet. Okay, so there were some questions about testing, and some of these answers will be specifically Las Vegas centric, but we do have some information on Utah as well. I wanted to take a step back a little bit and talk about what we're talking about in the medical community about testing. There's basically two kinds of testing being done now. The first one is testing to find out if you have the virus right now. This kind of testing we call PCR testing, polymerase chain reaction. It's a kind of test that is basically looking for what I call the fingerprint of the virus. They're looking for some genetic material that the virus would have left behind. And unsurprisingly, since this is a respiratory virus, we're looking in the back of your throat for this virus. You could also cough up some phlegm. That's actually a very good way to look for this. Most tests is done what we call a nasopharyngeal swab. It's a very small Q-tip, smaller than a regular Q-tip. It goes straight back into your nose to the back of your throat, and we test that, we pull it out, we put it in a special medium, and we send it to a laboratory. That's called PCR testing. It is a nasopharyngeal swab, and this is the test that tells you, are you positive or negative? Currently in Las Vegas area, UNLV next to UMC is doing the vast majority of testing in our community. There's been a small amount of other places that have been doing it on and off. The health department also has limited capacity to do it, but they're not open to the general public. They're using it specific for outbreaks in nursing homes and other facilities that are deemed really need these tests done. One of the questions was, is there a fee? Usually this is covered by insurance. I believe with some of the CARES Act and some of the stimulus packages that have been put out, the idea is that people should never have payment be a barrier to being tested. In fact, UNLV said that they won't charge anybody if they're being sent there appropriately and they are not able to pay for it. They'll charge insurance, or if they don't have insurance, there's no charge. To qualify for testing, there is criteria that's been set up. We do not want to test every single person in the community. If we do, Dr. Madison, that was a great example of using your elbow when you sneeze. Thank you. If we test everybody, we won't have enough tests.
Allergies.
Yes, I understand. Me too. There's not enough test kits. We keep hearing about that. It's a nationwide, it's a worldwide shortage. So we have to be very careful in who we decide to test. For the most part, we are testing people who are very, very sick, who maybe need to be hospitalized. We're testing healthcare workers with symptoms. The general public, if you have some symptoms, like for instance, I'm sneezing and coughing every time I go outside, you should be contacting your primary care physician. In our office, what our recommendation would be to you is, first of all, is this just allergies? Is this a simple cold, or could this really be coronavirus? If it's coronavirus, we're going to be asking a set of questions. We're going to be what we call triaging you. How bad is this? Since we know 4 out of 5 people, and it's probably a lot more than that, get super mild cases or just a really bad cold for a few days to a week, we're going to recommend you stay home, you self-quarantine. To run around town trying to get a test is not so necessary. We would like to get to a spot where anybody who has any symptoms could get this test. We're not there yet in our community. And I'm going to switch over to antibody testing next. But before I leave PCR, Dr. Madison, did you have anything to add there?
Yeah, no, I was just going to say, so the School of Medicine here in Las Vegas, you know, you can just contact that phone number and they'll do the screening for you over the phone. And then if you meet the criteria, then you can get an appointment and then you just go and drive through with your car. So that's really convenient. And then also there's now a new home test that can be done. So it's through LabCorp. So again, it's ordered through a physician, but it's based on a criteria. So they do a screening tool and then the physician orders the test and then the patient can get it to their home and then they basically just put it in the mail. So that's a new development that was just approved last week. So there is the LabCorp by Pixel home test that can be done if you're symptomatic, and that can be ordered by a provider.
Yeah, and a lot of the lab tests take several days, 3 to 7 days to turn around, which obviously doesn't help you right away, but there are some more rapid tests as well being developed.
Yeah, and then I know in Utah, they're using a contact tracing tool. So it's an app that the state has released and you basically put your symptoms in daily, and it's because it's your phone, it tracks where you are and it actually will tell you if there's any hot spots in your area. And then once you put in your symptoms, it'll tell you if you're low, medium, or high risk. And then after that, it will direct you to where the closest testing center is based on your risk stratification.
That's exciting. That's great to hear.
I know, right?
Yeah,
they've been doing that for about a week and a half, I believe.
Yeah. So, you know, one of the questions was, can we go to our PCP and get tested? First of all, if you think you have coronavirus, please don't get in your car and show up at your doctor's office.
Right.
Call them, explain what's going on, tell them their symptoms. As you said, they can ask you the test. They may have the capacity to do the test there. I can be honest with you. I know in our practice, we haven't been able to do the testing for a number of reasons. Close proximity. If we had people coming in all day, in and out of for testing, we don't have enough PPE to do that. It would put our other patients who have to come into the office at risk. So we really try to triage people and keep them out of the office setting for that. Is it a part of prevention and wellness? No, but you know, I do think it'll be covered by insurance plans.
Yeah, and then just to kind of piggyback on your statement about the CARES Act. So the provision within the federal government is that no COVID-related testing or treatment is not covered. So if you are uninsured, it will all be covered, and basically the provider would just bill and will be reimbursed at Medicare rates. So you should not have to pay for any COVID-related testing and or treatment related to COVID. That's all been funded through the federal government. Obviously, if you are insured, we will bill your insurance, but if you are uninsured, that should not be a limitation to you getting care.
Good. Let's pivot to the antibody testing, because I think that's the sexy new test that everybody's excited about. As a backup for everybody, antibody testing is checking your body to see if it's mounted an immune response to the COVID-19 virus, the coronavirus. I'll use the words interchangeably. I think we all know what we're talking about. So, you know, IgA is an immunoglobulin that our body produces very early on when we get an infection. It tries to overwhelm the infection and then it goes away. It doesn't stay forever. IgG is an immunoglobulin that stays in your body oftentimes for the rest of your life. For instance, when you had the measles vaccine, or you happen to be like me and got the wild chicken pox when you're a kid, you develop lifelong immunity because your body, first it produced IgA, then it produced IgG. The IgG stays around forever. It lurks in the shadows, and if that Same virus, use varicella, which causes chickenpox, was if I ever get exposed, that IgG comes out, overwhelms it, it would never cause me symptoms again. So one of the things we're talking about now is, I've had the coronavirus, am I immune? There are now tests that are done. These tests usually will check both IgA and IgG. One of the nice things about these tests is they tend to be a rapid test. You know, we're talking about doing drive-through testing where you come in at 3:30, I get your blood, I put in the machine, 15 minutes later, you know whether you have antibodies, both IgA, meaning you're actively fighting something now, or IgG, meaning you did fight it and now you're immune, supposedly, or you don't have anything. Very much like a pregnancy test that you can get over the counter or at your physician's office. So these tests are exciting, and there's been a lot of excitement around, you know, can we get these? There are several tests now out that I'm going to defer to Dr. Madison because I think she could talk more about each of them individually. These tests are rapid, they'll give you some good answers, but what we're finding out is, because this is a crisis, because it's a pandemic, we don't have a year or more to test these under controlled subjects and decide how good these tests are. We're basically examining these tests and deciding if they're any good while we're using it right now, and trying to make decisions based on these tests, even though we don't know how good the tests are. Some of the tests that have come out, they're under special approval. They're seeing 40% are false positive and another 40% false negative, which means just because you get that test and it gives you a result, it doesn't mean that result is right. And there's a very large chance that it's wrong. So these tests are available. Your doctor can order for you. You can go down to your local laboratory. They'll take some blood, they'll run the test, and you'll get a report back. We still don't know how good that is. So I try to explain this to people, and I'm honestly telling people to wait a little bit before they run out and get these tests, because you're probably going to want to get it again in a couple of weeks. Dr. Madison.
Yeah, so this is the new hot topic of the moment. I would agree. And so just to reiterate what you said, you know, the testing that we're doing right now for symptomatic people, we are looking for the virus itself. The antibody test is the memory, right? It's the memory of the fact that your body got infected. And so one is looking for the virus and one is looking for the memory that your body responded. So the testing that's available, there's currently only 8 tests that have what's called the emergency authorization use by the FDA. So you can go to the FDA's website and check to see if the testing that you're looking at obtaining is on that list of 8 that have been granted that emergency authorization utilization. However, I will say that there's a difference between what you were saying before, which is sensitivity versus specificity. So how sensitive your test is, so is what I'm finding actually, is me looking at this saying that you actually have a positive antibody, is that true? Versus the specificity, is that antibody actually specific for COVID-19? And what we're seeing is that the validation portion of these tests is lacking right now. We have not been able to truly validate the tests in real time because we don't have enough people that are actually infected and recovered. So let's just take, for instance, if you have 10 people and of those 10 people, only 5 truly have had it and would potentially test positive. If you test all of those people and your testing results come back and 8 of them come back positive and only 2 come back negative, that means, 1 in every 3 times you're actually falsely telling somebody that they're positive and not really knowing for sure if they've actually developed an immune response. So that's where we're at right now. It's, if we're using these tests for the purposes of potentially reopening up our economy, it really has to be right. And we have to know that when I tell you for sure that you are immune, that you are truly immune, right? And then when I test you to see if you are actually infected, I need to know for certainty, yes, you are actually infected. So that's where we're at right now with the antibody testing, and it's still evolving. It's still, you know, we're getting better. You know, when we talked, when we were prepping for this question and answer session, and when this question came in, there were only 4 tests that had their emergency authorization use. So every day there are more tests that are getting, you know, approval by the FDA, and the more we use them and the better we get, you know, I think we will get to a point where we might get, you know, sort of what we use as healthcare professionals as, you know, we all have to be tested for tuberculosis, right, before we go into any medical facility. So I think we may get to that point where, you know, we're testing for immunity to determine, you know, fitness for, you know, for work. But at this point, I just don't think that that's something that we can use that test for right now, because there's just too many unknowns.
Right. And the hope for this would be when the tests are really good, we will really be able to say, Dr. Madison, you clearly have had it and you're immune to it. Go about your business. Don't worry about it. Some people have referred to this as immunity passport. You'll carry around a piece of paper.
Yeah.
In China, they actually had an app that they would send out to you that showed that you were now cured. People have talked about a tattoo or a wristband. It doesn't matter, but something that shows you've had it immune. We don't really know. First of all, these tests aren't good enough. Maybe I just had the simple cold last week and it's showing up that I had coronavirus when it's not true.
Right.
And it doesn't mean that in 6 months I couldn't get it again. So we really hope that this will work, but time will tell.
Yeah, we got to get that validation piece, and I think it has a lot of great promise. That's for sure.
Yes, it's a key. It's a key to us getting back to business as normal.
Absolutely. Trying to advance my slide here. There we go. So I think you actually touched on this a little bit. So where can someone go to be tested?
Yeah, and I would just say, first thing is you call your provider's office. Call your office, describe what's happening. They can send you where they see fit. Maybe they can do it there. Maybe they can send you to UNLV. There may be some lab testing they can do, but call.
Yeah, and if you have questions like this, you can go to your local health authority's website. So Southern Nevada Health District's website is very good. They have a hotline that you can call if you have questions. I know that in Utah, their state health department also has a very informative website and an info line that you can call if you have COVID-related questions and specifically find out where you can go to get tested.
Okay, so can you explain the antibody test and how that's different from the viral testing? I think I've done that, which is good.
Yes.
I got ahead of myself.
I think we kind of got a little far ahead of ourselves.
Yeah,
but
that's
yeah.
okay. And will the COVID-19 antibody test be available, Clark? So as you said, it is now available. As I said, it's now available. If you call your doctor's office, talk to them, they can order it, but just remember there's a lot of limitations there. If you do it today, you're going to probably be calling again and asking to do it again in 3 or 4 weeks. So unless, you know, have that conversation if you feel it, but I would hold off on that.
Yeah.
Healthcare providers, oh, sorry, go ahead, Christina.
Oh, no, I was just going to say for those patients who for sure, like they were either hospitalized or had a confirmed COVID-19 RNA test, so they actually tested positive for the virus, the potential for doing the antibody test now may be useful if they wanted to maybe donate plasma, because there is, and I'll talk about it in a couple of minutes when we talk about the treatment aspect, but convalescent plasma is a concept that we've actually seen with other novel infections like Ebola, and it is being seen and been used with some success. And so if you have recovered and you know you have a confirmed diagnosis, and we want to test you to make sure that you have those antibodies, you may be able to save someone else's life by donating your plasma. So I did want to mention that.
Excellent. And then will healthcare providers be offered the COVID-19 antibody test before the general public? Time will tell.
Yeah, I agree. I think the stratification of testing will be prioritized for those who probably are high risk and would need to know whether or not they could safely work. So, I mean, in theory, I would think that healthcare workers would be at the top of whatever that list looks like. Okay, so medications used to treat COVID-19. So as of right now, there is no specific treatment or vaccination that has been approved for COVID-19. However, right now what we are recommending is what we call supportive care. So for, for mild cases, that includes, a fever, a cough, potentially shortness of breath, obviously. If that becomes significant, then we would recommend more acute medical attention. But if you're trying to treat your symptoms at home, the first thing that I would say is that I would make sure that you are isolating yourself from your family members so that you don't potentially infect them. So that would be the first thing that I would say. And then when you're treating yourself, lots of rest, good hand hygiene, making sure you're wiping down those surfaces so you don't have any cross-contamination, plenty of fluids, lots of rest, healthy diet. And then if you do have a fever, you can take some over-the-counter, products like Tylenol or Motrin, just any, fever-reducing agent. But you don't have to take it unless you actually have a fever. As far as the cough goes, you can take over-the-counter antitussive medication like Robitussin, things like that. But you would want to make sure that you're monitoring those temperatures and monitoring the cough, and then making sure that if you are experiencing any respiratory issues like shortness of breath, that if it becomes any worse, then you would want to seek some additional medical attention. So as of right now, it's really just like that OTC products until we really have an approved treatment. I know that there has been some chatter about the use of a medication called hydroxychloroquine or chloroquine. I do want to address that. So we do have restrictions here in the state of Nevada that the governor placed on the use of that medication, and also is being observed by our State Board of Pharmacy. But I do want to mention that the FDA actually did just come out with reports saying that they do not advise that hydroxychloroquine or chloroquine be used outside of the hospital setting. So it should not be used in an outpatient setting. So this would not be a medication that we would be asking you to take at home that would potentially help you with COVID-19. So those two drugs are being utilized, but they are only being utilized in the setting of a hospital case, and then under a clinical trial setting. So,
Dr. Madison, there was some noise right about a month ago about ibuprofen and not to
yeah, I want to address that.
That's kind of died down. I haven't really seen anything definitive. Anything to add there?
Yeah, so part of the where that came from, so it was a WHO press conference, and it was somebody who was representing the WHO just kind of as part of their their conversation, kind of in passing, had mentioned that there were some people who had been taking NSAIDs or non-steroidal anti-inflammatory medications, which includes ibuprofen, and that those individuals had had some worse outcomes, specifically renal issues. So, this is, goes back to sort of those like other chronic medical conditions. If you already have hypertension, if you already have diabetes, we don't already recommend for you to take things like ibuprofen because it can worsen your hypertension and cause challenges. So in that instance, the WHO actually came out with a statement and said, no, we are not saying that we do not recommend ibuprofen for fever reduction. We were just saying to take it in caution and take it based on medical advice.
Yeah. So I mean, if you'd asked me, I'd say start with Tylenol, and only if you don't have a high risk factor and your fever can't go away with acetaminophen, then you can go to one of the anti-inflammatories, yes, including ibuprofen.
Yes, and as somebody who actually has an allergy to NSAIDs and had a very severe GI bleed, I'm not a huge fan of They aren't innocuous. You know, it's over the counter, but any medication could be potentially toxic. So, you know, if you don't have to take it, if you don't have a fever, then don't take it.
Definitely the most toxic over-the-counter medication there is out there, in my opinion. But that's another time for another.
Yes. All right. So clinical trials. So I've mentioned the WHO a couple times. So that's the World Health Organization. So their sort of strategy right now is something called the Solidarity Trial. And so that's sort of an overarching amount of trials that they have put a lot of resources in to study specific medications to kind of ramp up the process to see if we get some good data. So I'm going to just pull that up just a second. So the Solidarity Trial right now is testing certain medications, which include antiviral medications, anti-rheumatic medications such as hydroxychloroquine and chloroquine. So I'll just go through the list for you guys. And my background is actually that I work with patients who are HIV positive and sort of that other aspect of communicable infectious disease. So a lot of these drugs are very familiar to me because of my work in HIV. So right now they're looking at Remdesivir, which is a medication that's made by a company called Gilead. And I think that was a specific question that was asked to us also. So that medication was actually previously being marketed for SARS. And so it was already in development and it was in phase 3 trials, and then they didn't have enough patients to test it on. And so luckily that was already kind of in the works. And so it was very easy to kind of repurpose it and get authorization for use here in the United States to be studied and initially started being used in the Seattle area for very sick patients. So that's an antiviral medication that has specific activity against COVID-19. We also have a medication called lopinavir ritonavir, which is a medication that was being used for HIV. So it's an older drug. We don't really use it right now in current practice, but it's also being used in combination with something called interferon beta 1A. So those are 2 trials that they're looking at, and then chloroquine and then hydroxychloroquine. And then recently we just heard about New York State testing ranitidine, which is an H1 blocker. It's typically used for heartburn, but it's being looked at right now in a clinical trial in New York State for its potential for stopping viral replication of COVID-19. And so it's not the over-the-counter amount of medication that you take. This is high dose and ultimately being delivered intravenously. So this is not like nobody should be running out to get ranitidine. So I do want to make sure that I make that statement. Yes. So those are the drugs that are being looked at right now through the Solidarity Trial. That's at the WHO level. Those clinical trials are being done all across the world and are showing some promise. But we're still waiting for data. We're also looking at the use of what I mentioned before, which is convalescent plasma. So we also got authorization for new drug application from the FDA to use convalescent plasma. So basically taking the blood of people who've recovered from COVID-19 and then basically giving them passive antibodies, right? So if you can't develop them on your own by having the infection, let me take someone else's blood and then give it to you so that you can now fight off the infection, right? So it's really only being used in very sick and ill patients that are hospitalized. Yeah. There's a few other medications that are being
used. Say at UMC Hospital, they're doing that trial.
Yes, yes, perfect. There's a couple other medications that are being used, like things that modulate the immune system, because I mentioned before that issue with the cytokine storm. So they are looking at some immune modulating medications. They're not under specific clinical trials, but it's part of the cocktail that they're using with supportive care. And then they're also looking at the positioning of people when they're hospitalized. So, you know, we know that once you're ventilated coming off, or what they call extubation, leaving the ventilator and actually recovering is there's a lot of factors that go into that, but there's some studies right now that actually turning the patient on their stomach has actually been very effective for how well they're able to get them off the ventilator. So, you know, those are kind of the things that we're working on right now. They're all ongoing. We're collecting data. There's a lot of hospitals that are involved in clinical trials, like our current, you know, like UMC. And then, Dr. Hunt, did you want to add any more to those trials? I know that like the coagulopathies and sort of the renal issues, some people are having to be on dialysis. Some people are kind of fluid overloaded in the lungs. I don't know if you want to touch on that.
You know, I think what we're really seeing is that we're throwing the book at this virus. People are trying everything, right?
Yes.
4 weeks ago, I think that people were thinking they were just going to give everybody hydroxychloroquine, and now we're finding out maybe it helps the virus, but people are having fatal arrhythmias and dying from stuff. So don't do that.
Yeah.
You know, so there's a lot out there, low dose steroids. We are seeing a lot of fluid buildup in the lungs of individuals with COVID-19 pneumonia. So drying them out is something that we're seeing. I know my colleagues at the local hospitals are telling me that they're using a lot of Lasix. I've seen people talk about the use of other diuretics like acetazolamide, but at the end of the day, we don't know what the ideal way to do it is, but it looks like patients are doing better if you can dry out those lungs as much as possible with diuretics.
Yeah, I would definitely agree with that. And then addressing the coagulopathies so that you're not having like, you know, possibility of having stroke and, you know, cardiac arrest. There was someone that, there was a case report of someone who, you know, was having trouble with the anticoagulant that they were using, and they were only off the drip for like, I don't know, a few hours, and they threw a clot and ended up having to amputate one of their limbs. So, you know, this is not the flu, right? Like, this is not the flu. So we know that like we're going to have to like treat it based on symptoms, but then, you know, we potentially may have to just like, you know, do the kitchen sink of treatment. But, you know, a lot of hospitalists, a lot of emergency room physicians and ICU doctors, I applaud them because I feel like every day they're learning something new, like the, you know, turning people over, you know, trying to get people extubated, you know, all that stuff. It's funny. It kind of brings me back to my training days because that's where I trained, which was actually at UMC ER and trauma. So. And then to answer this last question about the sulfa, as of right now, there's no treatments that have any sulfa components to them right now. But again, we're still in kind of the infancy stages of these clinical trials that are looking at effective treatment modalities for COVID-19.
All right. So I think you hit this one already.
Yeah, so Remdesivir antiviral medication, it's being used obviously in combination with other supportive care, but it's showing some promise. It was used in China, it was used in France. So we'll see. We're using it here in the United States as well. It has authorization for use in the United States under clinical trials. So.
Well, it looks like we're running up against the clock a little bit, so we're going to run through the next ones a little quickly.
Oh, I think
when do you think a vaccine will be made? I'll give you my projection after you give yours, Dr. Madison.
12 to 18 months. So maybe first quarter 2021. I don't know. Johnson & Johnson's looking pretty good. The Sanofi GSK collaboration's looking pretty good. They've got about 3 candidates that are looking pretty promising. We've done some human trials for safety, nothing for efficacy yet.
Yeah, not as quick as we all hope. I think the quickest vaccine that ever got put out took 3 years. So 12 to 18 months would be really, really fast. Let's hope that can happen.
Yes.
You know, this one I'm going to go real quick because, again, I see that we're getting up against the clock. But, you know, I just want to reiterate what we're doing in the community is making a difference. Here in Nevada, we have really, quote unquote, flattened the curve. Our hospitals were really worried that they were going to be overwhelmed with patients who had to be sick, had to be in the ICU. You know, we built a portable hospital at Cashman Field. We have plans with 950 beds in storage at the convention center. So far, and we're not out of the woods yet, we have not had to use it, and the hospitals, while busy, are not teeming and overflowing. The whole idea of flatten the curve is let's make, there's still the same amount of people going to get sick, but let's do it over a longer period of time. So the sickest ones are not going to be shut out. One of the big things that happened in New York, if you've been watching, is everybody got sick at once. It overwhelmed the hospital system, and we've seen the horror stories. So we talked about masks. They're preventing other people from getting sick. It prevents those respiratory droplets from running. Social distancing, breathing, coughing, sneezing. After about 4 feet, it tends to hit the ground, so it's less likely to be out there, though it still is. That's why we're using 6 feet of social distancing. You know, as far as phased opening, it makes sense. We want to see ability to have everybody tested. We want to see less people in the community showing up with viruses. We want to make sure there's capacity in the hospitals, because when we open, we might get a bump. And if we get a bump in more cases, we have to shut it down again. So the idea is to really give it a few weeks and see it every day. We're seeing less cases, less deaths, less hospitalizations, less percentage of people who are tested or positive before we start to open. And I'm hoping we'll see that in the next, at least phase 1. We're in phase 0. We haven't opened it all. In the next 3 weeks or so. Keep my fingers crossed.
Yeah, I mean, unfortunately, what happens is if you see an uptick, you got to start the clock all over again.
That's right.
Yeah.
So then we'll be closed for another 2 weeks.
Yeah, I think that's probably reasonable. I know that there's lots of businesses that are working on their reopening plans, but whatever that reopening plan looks like, it's not going to look like what it was before. So, you know, we will get back to work. It's just not going to look the same, at least for a little while. So, but I want people to know that, you know, there is hope. Things will get better, and that we know that as a society, we can come together and we can do things that may be uncomfortable for ourselves, but are what's really best for the greater good. So whenever I talk about public health, I tell my students this all the time. It's not about the health of the one, it's about the health of the many. And when I treat, you know, one person's, you know, hypertension or diabetes, it's great for that one person, but it's not really doing anything else for the community. When I treat somebody for, you know, an infectious communicable disease, like in this case, we're talking about COVID-19, but think about tuberculosis, which by the way, used to be a huge problem in the United States. I was trained in 2009, and at that time, we still had one TB sanatorium in the country, and that was in 2009. Like, that's crazy, right? So we have the ability to get this done, right? And we are all capable. It's just going to look a little different. We might all have to work on how we smile with our masks on, but we can all still connect and we can all still be together. It just may look a little different.
Thank you, Dr. Madison. I want to go ahead and switch over. I want to thank the Clark County Credit Union, and I want to thank Craig Faley for coming on today and participating in this panel discussion. We're going to switch over to Craig now so he can take us home. Craig.
Hello. I'm looking for the video. I still see the, thank you, the screen that came up. So I don't know if you guys can see me, but can you hear me okay? All right, okay, great, thank you. I want to thank Vanessa, Dr. Madison, Dr. Hunt for a fantastic talk. As the Medical Field Credit Union, we are very proud to sponsor Roseman's Neighborhood Health Series talks. And how can you protect yourself financially during this time? Unfortunately, the fraudsters come out of the woodwork during any natural disaster to try to access your funds. And unwittingly, most of the time, you've given them the information they need to access your accounts. So you want to watch very carefully any communication you receive, whether it's an email, a text, something in the mail, a paper product in the mail. The things you want to look for are misspellings, logos that don't look right, and if they're asking you any pertinent information. Keep in mind, the credit union will never ask you for your login, your password, your account number, We'll never ask you for anything that could be used to access your account. And if anybody's asking you for that information, you want to either hang up the phone if they're calling you, do not click on a reply, do not respond to a text, don't click on any links on an email, and don't call any numbers they give you on a paper product unless you know it's the actual credit union number, 702-228-2228. If you have any doubts at all about any communication you're receiving, stop, call us directly. Also on our website, we have a COVID-19 information page, which is monitored and updated daily. We're keeping track of what people are trying to do to rip people off. You can go to that page to get advice and guidance on what to do to protect your accounts. If you come into one of our branches, we of course have changed how we do business. As an essential business, we are open, serving our members like we have been since 1951. The differences you're going to find when you come in are social distancing, where you're standing. We have plastic barriers up to protect both our members and our staff. Also, the transactions that take the longest amount of time to do, like opening a new account or signing loans, can now be done remotely. So you can do those right from your phone at home or on your laptop. We have greatly expanded our online banking system. Most banking services you can now do right from home, so you really don't have to come into a branch. We've also expanded our ATM network. We've joined what's called a co-op, and that gives our members 30,000 free ATMs all over the country. Every 7-Eleven, for example, free ATMs. Again, minimizing having to come into a branch. You can go onto your Android or your Apple store and you can download, it's called Co-op Locator. It's a free download, and it will show you where all the free ATMs are to your location. And so we've done that as well. So keep in mind, just to wrap this up, that the bad guys, the information they need to get into your account, they're going to try to get that from you because they can't read your mind. But if you give them any information, it's going to be on a link you responded to, an answer you gave on an email, or a number you called that you don't want to call. So that's the most important advice we can give is if you're in doubt of anything, call us directly. Again, I want to thank everybody for a great talk. This was fantastic, and I hope everybody got a lot of information out of it. So thank you very much. Thank you,
Craig.
Thank you,
As a
Craig.
proud member of the
Thank you.
Clark County
Thank you so
Credit
much,
Union, I can give a cheer for that.
Thank you. We're glad you're here, and we'll be here tomorrow and beyond. So thank you so much.
Yeah, thank you.
Thank you so much for all you do for Roseman.
Oh, we love you guys. It's great. We're happy to do it.
Okay.
Dr. Hunt, Dr. Madison, was there anything else you wanted to cover? Moments?
No, I mean, if there's anything in the chat box that we can answer, maybe, because I know we had sort of a structured approach, but oh, looks like somebody's wanting to chat with us. Oh. Yeah. Well, we will now open it up to the floor for questions. How's that? Yeah. I will say though, as far as communication goes, things like this and being able to have, these kinds of question and answer sessions, I think are really great for the public at large, because in addition to us currently having a pandemic, we also have what I like to call, and what WHO is calling, an infodemic, right? So we're seeing this tsunami of news and information coming out, and it's challenging, for people to really understand, is this a reputable source? Is this where I should go? And kind of, how do I filter out the noise? And so I think it's really great that, the Neighborhood Health Series has really stepped up to kind of fill that need. Because I do think that there are a lot of people who are unsure of where to get their information from. So thank you for allowing us to come on and really to discuss things that are, needed in our community, and then also giving us a platform to really discuss our passions. And I know, Dr. Hunt is very similar to me in this, thought process of really wanting to be of service, right? Be of service to, not just to, our patients, but really for our communities, and obviously to Roseman as well. But I feel very passionate about, making sure that we get factual information out to the public. So I think that's great.
Yeah, it looks like somebody was asking a question about our own practice, the Roseman Medical Group. We're open for business. We've never closed. one of the things that we did about 6 weeks ago is March 16th. I remember because I was supposed to be on my way to Disneyland, which was closed, was we took our office and said, listen, we have a lot of elderly, sick, high-risk patients who come in here. We really need to switch over to the televideo, telehealth option where we can see our patients, we can talk to them on the phone and manage their chronic conditions, manage their acute conditions, but really triage who should and shouldn't be in here. But to have a waiting room of 20 people where 2 people might be coughing, that's not what you want in a physician's office. You know, we take care of older patients with neurological diseases. We actually switched to about 90% telehealth over those first 2 weeks. And now we are actually working on our plan to open up again once we get the okay from the governor to provide services. And just like we mentioned earlier, it won't look like it looked 2 months ago. People are being checked at the door. People are wearing masks, which is a new fashion statement. If you don't have enough masks yet, it's time to go out and get some because we'll be wearing them for a while in my estimation.
Yeah, and I just wanted to also say, if someone has tried a few weeks ago maybe to get into their provider for testing, and if they are still experiencing symptoms, I would try contacting them again, or you could always go through the UNLV School of Medicine route because they do have tests and they are pretty good about getting people in if they meet that criteria. So if you are still worried about getting tested, you stay in your car. Like you don't have to worry about, you know, being around other people if you're worried about going into your primary care provider's office. The other issue, or
I'm just going to want to reiterate on that one, Dr. Madison, though, if you're not having any symptoms,
right, you have to be
to get a test is not going to help. In fact, you'll be taking it away from somebody who really should have it. So, you know, you may have pre-existing conditions. If you go outside and sneeze, that's not enough reason to go ahead and get it. Now, if you're having cough, if you're having fever, if you're starting to develop shortness of breath, if you're starting to have the severe symptoms, that's a very different story. And then you need to reach out to your doctor and find out what you should do. And
there's also the LabCorp home test now. So if you contact your provider, you say you have symptoms, they can just send you the home test and you don't even have to step foot in the doctor's office. So there's that too. I'm checking the chat box to see if there's anything else.
I think we hit them all.
Yeah.
Vanessa, you want to take us home?
Yeah.
Yes, well, thank you all for being here and thank you for being patient with us as we try this new approach for the Neighborhood Health Series. Thank you, Craig Fraley and Clark County Credit Union, and thank you, Dr. Hunt, Dr. Madison, Jason, Cameron. Have a great night.
Thanks, Vanessa. Thanks, everybody, for spending the day with us.
Thank you.
Bye.
Thank you, Cameron, for making it work.
Be safe out there.
Good night.
Good night.